Hi, everyone, and welcome to MGFA's Wellness Series webinar, Managing Tertiary and Secondary Symptoms of MG. My name is Jenna Mbalo, and I'm the Director of Patient Advocacy and Community Engagement at the MGFA. I'll be moderating today's session. Before we get started, I just wanted to let you know that you can submit questions during the presentation in the Q&A box located at the bottom of the Zoom menu. This session will be recorded and available to view after the presentation. I'd like to give special thanks to the support of our sponsors, Alexion Argenx, Janssen & Janssen, and UCB. We've got a great presentation ahead, and now it's my pleasure to introduce you to today's presenter, Dr. Tom Pitts. Dr. Pitts is the Director of Neurology at Hudson Medical and Wellness. He treats the entire spectrum of neurological illness and has a personal interest in MG. He provides customized therapeutic approaches to meet the needs of each of his patients and is an expert in the medical and interventional management of all headache syndromes. Dr. Pitts provides care in English, Spanish, and Italian. He also participates in the MGFA support groups, including the New York one, the Spanish-speaking one, and the Houston one as well. And he is also a partner in MG Care. Dr. Pitts, welcome, and I'll hand it over to you.
Thank you very much. And I'd like to extend a really nice welcome to the entire MG community who has taken the time to join us today. We have a wonderful, wonderful topic here today, and I'm going to show you some slides. We're going to go over some of the things that extend beyond the power, right? So we're going to be talking about some wellness topics, especially secondary and tertiary symptoms. And if you're not sure what I'm talking about, don't worry. We're going to go into detail here in just a second. So I'm going to share my screen here, and we'll get the PowerPoint all loaded. And I will start the slideshow from the start. All right, folks, without further ado, again, I'd like to thank all of you and the Myasthenia Gravis Foundation of America for putting on this wonderful series. I'm honored to be a part of it. So let's start, gang. So let's talk about the management of the secondary and tertiary symptoms of myasthenia gravis. This is a massive source of confusion, sometimes misdiagnosis, and it may also lead to folks, frankly, being adjudicated as a mental health patient, because it's hard if you don't deal with this often, and if you don't have a 10,000-foot view, it can be hard to tie these symptoms together. They don't seem related to a disorder, a neuromuscular disorder of voluntary skeletal muscle. But as you do this more often and you get a little more experience with it, it kind of becomes clear. So we'll go over some certain scenarios. I plan on talking about a wide host of secondary and tertiary symptoms, but let's talk about what that even means. So if you look down, secondary and tertiary symptoms refer to overlaying symptoms which do not directly occur from myasthenia gravis, meaning if I take a mouse model and I block the acetylcholine receptor or the MuSK or the LRP4 antibody, you know, they tend not to have anything beyond skeletal muscle fatigable weakness, right? Now, we don't ask the mouse or rat that we're studying, hey, did you lose your job as a truck driver? You know, do you have depression because you weren't able to hang out with all the other non-MG rats or mice, right? So a mouse model, a rat model, which is the gold standard of pathophysiology, really does not come over to the human side where we have normal lives, families, kids, ourselves, our employment that we have to consider and take care of. So I just mentioned that they are not directly at the biochemical level related, but they happen. So if you look at the other side, we have a diverse downstream effects indirectly caused by simply living with myasthenia gravis. I'm going to show you some prime examples across some of the organ systems here. So let's talk about some examples. I kind of set up two examples of how a primary symptom kind of bursts a secondary symptom, and it can create a tertiary symptom. So let's talk about the primary symptom, let's say leg weakness, okay? So now my legs are weak from myasthenia gravis. And if you just look at it from a grassroots level or a grass level and not a tree level, you're going to say, well, okay, that's perfectly explainable by MG. But now all of a sudden a patient comes in and starts to say, you know what, I'm having urinary incontinence. You know, I'm not able to arrive quick enough. And I also feel that I have an increased urge. So it's like a double whammy. I have to go suddenly and my leg's weak, so I can't get there. So a secondary symptom would be from the MG, right, the leg weakness, And perhaps a medicine like methanol or an acetylcholinesterase inhibitor, one of the examples that can increase urinary frequency. So there's your secondary symptom. But now the tertiary symptom, right? So if you're having urinary incontinence, maybe, let's say frequently, and I invite you to a birthday party and you're unsure of the bathroom setup, you're not at home, it can be very daunting to want to go to an event like that, much as you may want to. It's your friend, it's their birthday. There's social anxiety and potentially depression after the fact. So you have social anxiety because you're saying, I want to go. This is my best friend. They're going to be disappointed in me if I don't go. I went to high school with them. I went to college with them. Maybe I'm the godfather of their kid or something. But I don't want to have a public embarrassment and urinate myself. So I'm not going to go. So there's anxiety. Then there's depression because you didn't go. And you realize how much this disease is impacting not just your leg weakness, but your whole life. So that's how a primary symptom causes a secondary symptom, causes a tertiary symptom. Let's talk about another example. I see this all the time. I'm a subspecialty boarded neurophysiologist, but also a subspecialty boarded headache doctor, and the two go hand in hand. So head drop, right? Neck extensor weakness. Most all MG patients have had trouble picking their head up, or it felt extra heavy. So the primary symptom is neck extensor weakness. That's myasthenia all day. But now I'm getting a headache. And you may have heard the term pure motor, and I'll talk about that later. A lot of doctors might turn around and say, well, that has nothing to do with MG. It's a pure motor problem, MG, just weakness. So pain, numbness, tingling, these are not part of MG. Now, they're not wrong, right? In the mouse model, blocking an acetylcholine or MuSK or LRP4 receptor does not cause a migraine. But I always tell people, hey, why don't you hold the heaviest bag ever on your shoulders and put your head down like this for about 10 minutes. Don't even do it the whole day. And then you go and tell the MG patients that walk around like that there's no reason for them to have neck pain. So it becomes very obvious when I say it like that, right? I go, hey, look up at the statue. I'm in New York. Look up at the Statue of Liberty for 2 hours and tell me that that had nothing to do with your neck pain, right? So MG, of course, indirectly can cause headaches. And then lastly, when you have a headache, especially a neck headache in the back of your head here, it can become extremely difficult to achieve quality sleep. Even if you don't wake up, you can come out of restorative sleep, REM sleep, rapid eye movement sleep. You've all heard of that, the deep sleep, if you will. So when you have a headache and neck pain, you certainly can have non-restorative sleep. So that would be a tertiary symptom. And if I even want to go a step further to a quaternary symptom, you can have brain fog or suboptimal cognitive performance because you have chronic pain, you now have sleep disturbance, and you have maybe some anxiety or depression about these things and the fact that you have MG. So these are tied into the MG syndrome. Although they're not primary symptoms, we know that they are correlated with MG, not because they have to do with the direct blockade of the receptors and the weakness, but because having this disease precludes you more so than the general population to have these symptoms, which is why so many MG patients consistently report them. So these are underappreciated and confusing, right? A lot of people are blown off, or maybe the doc is well-meaning and they just aren't sure how to tie it all together. But I can tell you that they are confusing because they often seem to have no direct pathophysiological relationship to a neuromuscular disorder. But we just showed you some examples of how they spawn from having a neuromuscular disorder. Now, I would mention that failing, in my opinion, to recognize and value and certainly address or manage these secondary and tertiary symptoms can absolutely have a major downstream impact on a patient's health or well-being. And I'll talk about how sometimes those downstream effects can have a much more adverse effect on a patient's health than even their MG sometimes. Now, thankfully, we've moved into more formalization in this field. We have quality measures like the myasthenia gravis activity of daily living for subjective patient-based measurement of symptoms. We've always had the famed Myasthenia Gravis Foundation of America classification. But I want to point out the MG-QOL 15, which I listed at the bottom. That's the Myasthenia Gravis Quality of Life 15-point questionnaire. And it helps to address things like, does my MG frustrate me? It helps us see and appreciate some of these symptoms beyond the power deficit or weakness. Let's talk about pain. I told you I'm going to break down some common secondary and tertiary symptoms that I see in the clinic. So I might get a myasthenic patient that comes in and says, no, double vision, not really, swallowing, chewing, talking, arm, leg, okay. Headache. Where's this coming from? Never had headaches before. Well, upon further investigation, now, very tempting thing to do, and I see this done poorly a lot. Headache does not equal migraine. Migraine is a very specific type of headache. The most common headache, in my opinion, in neuromuscular disease, especially myasthenia gravis, is called occipital neuralgia. And I'll show you what that is. It's an impingement of the disc in the neck from strain or overuse, and it causes a headache. And a lot of you, I know, are going to shake your head when you hear this, because this is so common in this community and underappreciated. Back here, you may have a radiating pain in the back of your head. It can even shoot to the back of your eye. You may experience pain in here. I've seen them incorrectly called tension headaches. I've seen them incorrectly called migraine headaches. And then what's worse is you're put on a migraine medicine, which may potentially not play well with your myasthenia, and you didn't have a migraine to begin with. You had a neck issue from myasthenia-induced neck extensor weakness or head drop. So again, I talked about it. We're taught that this is a pure motor disease, just like ALS or Lou Gehrig's disease, pure motor disease. But that's taken out of context. The reason why we said that, the reason why we use those words is we don't want neurologists to confuse this with a neuropathy, which is a disease of the nerve, not of the neuromuscular junction, in which case the primary deficit is usually, tingling, numbness, burning, sensory problems. We call them paresthesias. We call them dysesthesias, abnormal sensation, and there may be some weakness later on, especially if the axon or main part of the nerve is attacked. Myasthenia, we said that because we didn't want people to come in with a whole ton of numbness and stuff and be called neuromuscular junction. We want you to go down a neuropathy route. But that's been taken gravely out of context in myasthenia gravis. Now, I feel like a lot of times patients tell me any pain complaint, any numbness or tingling is often kind of underappreciated or not seen to be tied in with their myasthenia gravis because it is a sensory symptom. I'm showing you the occipital nerve. That's the occipital nerve, the big red one. Now, that's not a three-dimensional picture, right? So in the picture, it looks like it goes here, but that nerve goes over the head here, and it kind of goes, you can feel sensation behind the eyes. I want to definitely point your attention to the neck part. You'll see that that is red too, and very often there is a disc bulge or disc out of place in the neck, pushing on the nerve, radiating pain all over the place. And then you can imagine, you lay your head on the pillow, it presses on that nerve, you toss and turn, even if you don't wake up. You now have non-restorative sleep, which can preclude you to have accidents, more myasthenia weakness, and definitely brain fog or suboptimal cognitive or thinking performance, okay? Even if you don't have a disc out of place, which is the fluid-filled sac between the bones in the neck or the vertebrae, just muscle strain, right? I mean, if my neck extensors aren't working well, like a muscle called the splenius capitis, for example, other muscles have to do twice the work. And if anybody's ever been to the gym, when people don't understand this, I say, look, do like 200, bicep curls and tell me your arm doesn't ache, So you can see here when I make these kind of easy, obvious analogies, I think it becomes clear, but this has been a source of confusion, as easy as it seems, for so many people for decades. And I hear about this almost never when we talk about myasthenia, even in academic circles. So we're here today as a collective to bring awareness to these type of things, because we're done with you folks being disparaged and blown off when you actually have a very logical neurologic problem that is very obviously, indirectly, but certainly correlated and directly resultant from your myasthenia gravis. I'm very proud to talk about this today because I'm getting loads of MG patients with these symptoms, and I hear the same thing. Everyone said this wasn't part of my MG. Well, I'm happy that we're moving in the right direction. Now, I wrote on the bottom occipital neuralgia, but I should mention that when you have a headache, in my opinion, one of the last things you want to do to a myasthenia patient is introduce oral medicines that are non-myasthenia related, if you can help it. We know that medicines not only mess with the metabolism of other medicines that you may be relying on for MG care, but furthermore, When you start introducing medicine, you always run the risk that they can provoke or exacerbate myasthenia. We know that myasthenia is exquisitely reactive and can become upset with exogenous substances, including supplements. Supplements are medications, guys. I'm going to talk to you about that in a little bit. Best part is when you have this kind of thing, the gold standard is a very small injection in the skin, right at where the head meets the neck. So not even in the muscle. You can do it in pregnant women. You can do it in children. It's something that can have months of effect. And then you get a picture of the neck, you show the injury or whatever, and you get some therapy going, like PT or some other exercises to strengthen the neck, and you work on their MG care. I look at headache as, yes, a problem I need to fix, but a sign of wider suboptimal myasthenia care. If you have a headache in your neck and you didn't like fall off a building or something that day, I'm going to look at that and say, wow, I think I've underappreciated your myasthenic weakness. We're up here talking about ptosis or droopy eyes, double vision, swallowing, chewing, talking, as we rightfully should. But that subtle headache should not just be pointing me in the direction of like, oh, a neck injury or something. It should really make me think, is there something I can do better to improve the neck strength? Because if that neck is weak, the next thing that's going to happen is swallowing and diaphragmatic weakness. So this could be a vital warning shot across the bow, subtle as it may be, that A, we need to get this thing fixed so you can get good sleep and cognition. But most importantly, we might be missing a crucial opportunity to improve your myasthenic care and totally knock out the problem. Joint pain. We hear joint pain all the time. Guys, myasthenia gravis does not affect joints directly. There aren't neuromuscular junctions in the joint, but you can have joint pain. How? Well, coexisting autoimmune disease, guys. HLA, here's your homework. Everybody's got to learn about HLA. These are the haplotype mutations. And if you look at them, you'll see that they are common across autoimmune diseases, right? So thyroid, diabetes type 1, ANCA vasculitis, I could go on and on, Sjogren's, lupus. That's why so many MG patients have a coexisting autoimmune disease. And if you don't find and address those, the myasthenia will become refractory or harder or more difficult to treat, or you may need more medicine to treat it. So if you have another autoimmune disease, that could cause joint pain. Most of the rheumatologic based ones do cause joint pain, especially lupus or Sjogren's. You always want to think of that. Secondly, obesity. If you have a neuromuscular junction disorder and you can't exercise or move well, or if you can't eat healthy foods, maybe there's more cumbersome foods to eat that you avoid because of swallowing problems, and maybe there's a more easier to eat but not as healthy food, it's easy to see how an MG patient could become overweight, right? The cards are stacked against you. Now, that being said, however, if you do become obese, that is almost always a primary cause of bilateral or symmetric knee, hip, back, and ankle pain. Makes sense, right? I mean, try holding something above your head and tell me your neck doesn't hurt. So, we're not giving you a hard time when we say obesity. Please don't blow us off when we say that. We're not trying to give you a hard time. None of us are in great shape after COVID either. But that being said, right, I mean, I'm not doing you a service by telling you that your joints, don't need to have less weight on them. But in order to do that, I have to follow through with better MG care. Because what I'm saying here is that your obesity is almost certainly correlated and worsened by your MG, right? If I can treat your MG and get you moving better, you wouldn't have obesity. So that's what I mean to say is, instead of just saying, hey, the patient's obese, it's saying, wow, this MG is really affecting his or her ability to exercise, leading to weight gain, leading to joint inflammation or problems. And furthermore, I will add, we know that commonly steroids like prednisone are used in myasthenia gravis, and they have a role, indubitably, especially in short-term care, bridging to a steroid-sparing medicine like an infusion or a non-steroidal pill. But that being said, steroids over time certainly can preclude you to disc problems and bone problems, especially bone problems. So I talked about disc herniations, which you can see there on the right. There's a bulging or herniated disc, which is like a water balloon. When you step on a water balloon, it can bulge out if it doesn't pop, or it can pop entirely. And it pushes against the nerve, and it can send signals of pain up and down your arm, into your shoulder blade, down your buttock, into your foot even. That's called a radiculopathy. Now, you got to consider that, right? You got to look at that and say, okay, myasthenia helped make them obese by them not being able to move well. And because of that, maybe they were also on steroids, which can lead to weight gain. Maybe there was some bone demineralization. And now I got a disc bulge. So you can't just look at the disc bulge. Oh, you have a disc bulge. Let's do PT. I look at the disc bulge and immediately think, what did myasthenia and or the medicines that you were on do to at least contribute to that? I'm not discounting other things like ergonomics and posture, but with MG and especially the medicines that we use sometimes to control them, you really do have to consider these things, and that might be an opportunity missed, right? If you see this, you might really look and say, oh, let's get a bone density scan. It might be time to really pull back on these steroids if we can, go harder on the other non-steroidal drugs. I always say you get the gold medal. You get the gold medal in myasthenia when you put a patient in remission on little or no steroids. You don't get a gold medal when you put somebody in remission on a high dose of steroids. You get a medal, right? They're out of the hospital. They're not life-threatening. But make no mistake, we are contributing to downstream adverse health effects by doing that, okay? Burning, I get this all the time. I put up a depiction there. Guys, these are Christmas tree lights. That's all they are. You plug it, the plug, you take it out, all the lights go out. So yes, you can feel burning and tingling in your fingers. That can be from your neck. You can feel burning and tingling in your toes. That can be from your back. And that's called a radiculopathy. Now, cramping is a huge one, okay? I really want to talk about cramping. I get this a lot in the calves, wherever. Mestinon, pyridostigmine, the acetylcholinesterase inhibitor, can cause cramps directly. Keep in mind, electrolyte deficiencies can cause these. Anybody who's been dehydrated knows this, right? So why would you be dehydrated or undernourished? Myasthenia, right? I can't chew, swallow, or breathe well. So naturally, I don't want to eat a lot, especially not, protein-filled steaks or something. Those are almost impossible to chew when you have bulbar weakness. Keep in mind, you might have an ulcer or GI problem by the prednisone, and that could cause, amongst other drugs, that could discourage intake because it could hurt you when you're eating. And you can have diarrhea due to mestinon again, which can cause electrolyte and fluid loss, leading to cramps. Also, a pinched nerve in the neck or back can cause cramps along its distribution. So if I had an L5-S1 pinched nerve in the back, which denotes the level of the nerve right above the buttock, my calf might cramp because the medial gastroc or lateral gastroc, are innervated or connected to that part of the back. So I like to say that, you hear the story burning, cramping, it's easy it may be very difficult to imagine that they coexist from myasthenia. But if you look down at the second, third, fourth, fifth order downstream effects, it becomes really clear, right? Someone can't exercise because they're weak. So they gain some weight. Then they're on medicines that maybe irritate their stomach, and degrade their bones. Now they have a disc bulge, and with the disc bulge, they have burning down their arm. So it's not that far-fetched when you talk about it logically, but I think when you don't tie it together, it becomes nebulous. And I think a lot of these symptoms, I think a lot of visits go like, well, let's focus on the weakness. But actually, these are signs of subtle weakness that you may not be seeing in the clinic because it's a variable and fluctuating a problem, right? We know that myasthenics are better in the cold, typically better in the morning. We don't see you in the clinic at 10 p.m., So I don't see you at your worst. I ask for videos a lot. We don't see you at your worst. So I don't want to underappreciate anything when I'm seeing you at 8 a.m. That is why we do the MG-ADL, patient subjective, task-based measurement of strength. And we do a full history. We ask about things like back pain, headache, numbness, tingling, cramping, or we should be. Sleep. Man, I can tell you the quickest way to put another 10 years on your life or take away 10 years on your life, depending on who you are, is to fix or not fix your sleep. Sleep is one of the pillars of health that I will talk about. The true naturopath appreciates the pillars of health: mood, exercise, sleep, diet, exercise, nutrition. The goal of being a naturopath is not to do a race and see how many supplements I can put in my body. That's not naturopathy. We'll talk about that later. Sleep is a pillar of naturopathy. When I put on my New York face, I'm almost like, listen, don't talk to me about the silver, supplement you're doing until you're sleeping like a champ, till you're exercising like a champ, till you're hydrating like a champ. I want you on a preferably plant-based, cardiac healthy, protein-rich diet. You could consider paleo, some diet. I want those pillars of health knocked out before we start getting into like the cosmic realm here, okay? Now, sleep is a massive issue for any neuromuscular patient, especially a myasthenic. It cannot be understated. I have yet to meet there might have been one in like recent history. Almost always there's a suboptimal sleep complaint if you screen for it in a myasthenia visit. That can come from obstructive sleep apnea, which is, typically a short neck obesity issue. And we talked about how that could happen with MG. But remember, there's other sleep disordered breathings like diaphragmatic weakness that can occur during sleep. So imagine having a pinched airway, as can be seen in sleep apnea, and you have a diaphragm that doesn't always want to breathe for you. And you have back pain and headaches and the other things I talked about, plus the stress and anxiety that comes with that. I feel for the MG community. How many of you must wonder, will I wake up? You're not breathing well and you're going to sleep. What does that do to your psyche? And how can we not appreciate that as part of MG? In my opinion, that is a hallmark of MG care, is sleep. Keep in mind, medicines can compound this problem. Prednisone can keep you awake. Mestinon can make it so you have to pee every few minutes. Anxiety and depression that comes with this. Pain, it's a major issue. Headache. Restoring sleep is phenomenal for myasthenics and any human on the planet in terms of restoring injury, reducing inflammation, the nighttime dip in blood pressure and heart rate, which is cardiac protective, shown in multiple studies. Loss of the nighttime dip of blood pressure and heart rate directly correlates with heart attack and cardiovascular disease. So by sleeping, we're saving your heart, we're saving your mind, we're trying to help your MG. But we have to ask about these things and facilitate them and consider them as part of myasthenia gravis. We must. Brain fog, gang. I hear this all the time. It's not a medical term, but I know what you're trying to say. This is suboptimal cognitive performance. I don't feel as sharp. I don't feel as good. Guys, you're 20-something years old. You're 30-something years old most of the time in the younger group, right? You don't have Alzheimer's. You don't have, Parkinson's at 20. But you have a cognitive issue. How does that happen? And again, this is something that could easily be chalked up as a mental health issue, kind of to the less keen eye looking at a myasthenic. So let's talk about brain fog, okay? So I got a 20-year-old, 30-year-old, 40-year-old. You guys should be the sharpest people on earth thinking-wise, right? My 73-year-old dad, this old Brazilian guy, if I told him a 20-year-old had trouble thinking, he almost wouldn't comprehend that at 70. Happening. So how? Well, we talked about it a little bit, but sleep. If you are not sleeping, you are not thinking. There's some amazing data on people self-reporting, like they'll take them from 8 hours to 7 hours and then 6 hours of sleep. And they'll say, how'd you do at work? And everybody's like identically the same as when I had 8 hours of sleep. Not even close. Delay in time, especially when you go to 6 hours. And when you go lower, it almost becomes embarrassing. It's you're not even yourself at that point. Sleep plays a massive role in this. Medications can cause cognitive dulling, right? So slowness of thought, not really applicable in the MG world, but certainly in the headache world. Topamax or topiramate, a lot of people fondly call it Dopamax. And the reason why is it has a side effect on the label of cognitive dulling. Poor oxygenation. If you're not breathing well, you're building up carbon dioxide and have slightly low oxygen levels. Who thinks well when they're poorly oxygenated in their brain? You can have a mental health overlay, either primarily or from MG and all of this. Stress, anxiety can cause things like pseudo dementia or pseudo mild cognitive impairment, where basically you're depressed or anxious, not paying attention well, things like that, not sleeping well, and that can contribute to cognitive dulling. Keep in mind, many times this is happening in tandem. It's not A, B, or C. It's usually a combination of these. Systemic illness, okay? Thyroid issues commonly exist, especially the autoimmune ones like Hashimoto's or Graves, commonly exists with MG. And we know that thyroid disease is a dementia mimic And that is why the American Academy of Neurology says when you have a cognitive patient, you got to check their thyroid. That's why we also say in MG, you should check for other coexisting autoimmune antibodies, including thyroid. So thyroid, right, can preclude you to have thinking issues. And lastly, I talked about poor intake, like eating and drinking, and we talked about some of the reasons why that might be impaired. Keep in mind, you put 2, 3, 4, 5 of these things together with sleep, with MG, with pain. Who's thinking 100% with all of that going on? The question and underlying theme here is, or the point is, we have to start to connect these things to its origin. I'm not saying don't look for other issues, but you have an issue. I don't have to give you 15 other diagnoses usually, you know. You have an ultra rare neuromuscular disease that can create all of the things I just mentioned that can lead to brain fog. So now depression and anxiety, okay? So anyone who has a chronic illness with potentially life-altering and life-threatening consequences, who wouldn't have some anxiety or depression? You know, you're not alone. I always tell people, you know, I have a blood clot in my leg. I have to take a blood thinner for. You think I wasn't a little bit anxious or depressed, you know, when that happened? Of course I was. So that's something to think about. And I always tell people, you know, the way I kind of tease out primary depression or not is I say, listen, if I can magically magic wand your MG away, you think you'd still be sad? And a lot of them say, well, I've always kind of been sad, but other people say no. And that kind of helps me know, you know, is this a secondary issue? Are you just depressed because you have MG, or are you depressed naturally and MG just made it worse? Because again, mental health disorders are no less, and I have this written here, it's no less of a medical problem than MG is, depression and anxiety. All we got to do is be non-judgmental adults about this, okay? Non-judgmental adults. The stigma's got to go away. I'm tired of the stigma. I'm tired of sitting down with, you know, whether it's a doctor, you know, 50-year-old executives that can talk about anything, 20-year-old, and it's like taboo to mention anxiety or depression. Let's get over it, move on. Let's be adults. We'll talk about these things because they're medical issues, guys, and they can have a direct effect on your MG. They can have a direct effect on your sleep and rehab. That can go on to cause cardiac problems. We know that depression is a coronary artery disease, essentially risk factor. And I got to tell you, there's a big difference between saying that MG symptoms are in your head. No one's for that at all. But recognizing the secondary or tertiary symptom of depression and anxiety is vital and can lead to an amazing change in your quality of life that you will be the direct recipient of. So I'm always proud when someone is willing to just sit down and say, hey, Dr. Pitch, you know what? This isn't in my head, of course, but like, I'm pretty bummed out because, you know, I can't chew and I get invited to dinner parties all the time. And I have to tell my friends no. And if I do go, I end up spitting out food, you know, and I'm bummed about that. Thank you for telling me there's things we can do, namely fixing your MG. GI problems. Everybody has GI problems. I feel like I have GI problems. They're not fun. Then you start throwing on prednisone. Then you start throwing on mestinon. These are good for MG. We know that, right? But chronic prednisone can cause ulcers. Mestinon can, or acetylcholinesterase inhibitors can provoke diarrhea. Remember, I mentioned that other autoimmune problems coexist with myasthenia, and many of those, if you have one, can cause dysmotility or abnormal natural movement of the gut. The gut has a pulse. If you hung a person upside down and put food in their mouth, the mechanical wave, almost like the ocean, would actually transport the food, even though you're inverted through the digestive system. That motility or movement can be disturbed. And when that happens, you always think of something like, for example, diabetes or prediabetes that can be commonly found in the MG community. Type 1 is autoimmune, same HLA haplotype mutation as MG, or type 2 from weight loss and insulin intolerance, usually from inactivity caused by MG weakness. Thyroid as well can mess with gut motility. So when you hear stomach, you don't just say, oh, that has nothing to do with MG. You think, how can MG or an autoimmune disease like it that is known to coexist affect the gut? And let me do my part as the neuro and assess that and rule that out. I'm not saying don't go to the stomach doctor. Of course you go to the GI doctor, make sure there's not a primary problem, especially if you're a little older, if you're in range for your screening colonoscopy, those things have to be done, right? But let me tell you what, I've seen plenty of downstream effects causing stomach problems that are MG related and autoimmune related. Bladder problems, hot topic. I always make a special section for bladder. It's extremely complicated. I got to tell you, the bladder is one impressive organ system, and it's got all types of ways to dysfunction. And naturally, you can imagine, right? This causes grave debility and, frankly, embarrassment for people. And I'm very happy to help people with this issue. Not part of MG, guys, right? I mean, if I take a mouse model and I block all of its acetylcholine receptors, let's say I just kill it by doing that, the bladder's not affected. It's not a voluntary skeletal muscle. I'm sorry. But that being said, there was one group that caught my attention. There's a study, and I can include the link here after. Only a handful of patients, I think like 7 out of 100, reported bladder problems as part of their MG. They were all seronegative, which raised the question of a psychogenic etiology, right? Why is it the only people that don't have an antibody are the only people deviating from the book? Well, that's the nature of seronegative, right? I mean, look at Musk, look at LRP4. They're different than acetylcholine receptor antibodies. They were both previously seronegative, gang. So you take a look at this and you say, all right, all of these people who reported it had worsening of their MG. So is bladder dysfunction maybe not directly correlated, but a sign of worsening MG? Absolutely, it could be, right? We know that urinary tract infections worsen neurologic processes like MG. And I should tell you that there's a lot we don't know about seronegative MG. It's usually a group of antibodies we haven't found, like LRP4 and Musk. Both were seronegative. Now they both have a defined treatment plan. They both have a designed research arm. You could also have a coexisting autoimmune disease that I mentioned. You could also have coexisting diabetes, many of which do affect the bladder, especially diabetes and prediabetes. Should always see a urologist to make sure there's not a primary issue, but there are several types. Okay, you have overflow incontinence, urge incontinence, stress incontinence, neurogenic incontinence. They all have to be considered individually. We do need the help of a urologist when this happens. And I can tell you, though, that when you take a look at this, this can be a sign of worsening MG, but also if you have especially atonic or lazy bladder, if you will, it can retain urine and you can have urinary tract infections, which are known to worsen MG. So as soon as I hear bladder issue, I'm like, all right, let's take a look at your MG and let's take a look at other autoimmune or systemic problems. Let's get some good labs. Let's talk to your PCP and let's send you to a urologist and not wait on this. Now, I mentioned the urology appointment. If naturally, if you're a female, you would also want to consider an OB-GYN appointment, right? And there's also urogynecologists, just to make sure there isn't a women's health issue affecting the bladder. For stress incontinence or like coughing or laughing, sneezing with some urine drippage, usually from pelvic floor weakness, there are Kegel, pelvis floor stimulators. There's bladder stimulators, both external and implantable. I'm not, saying those are for everybody, but there are options. And actually for atonic or dystonic bladder or lazy bladder, tibial nerve stimulation, just shocking the outside of the leg there, has been shown to stimulate the bladder. Diagnosis and management of concomitant problems like diabetes is also key. Now, excellent topic. I don't see this addressed ever. I get these questions all the time. Of course I do. We are humans. To not talk about this as your doctor, it's like, what am I doing? I got to help you here, how to live with MG, sexual considerations and intimacy. So complex interplay of etiologies may affect your sex life. Okay. And I'm going to get poetic here, but look, I'm Spanish and Italian, and this is the truth. Body dysmorphic issues are massive. Okay. It is hard to feel beautiful when you are sick and when you're not in the best physical shape of your life due to your illness, okay? And you're seeing other people that don't work as hard as you did to be in shape prior to MG, being in shape, but you're not because of MG. And if you don't feel beautiful, intimacy can be an issue. And frankly, for some, especially female patients, not feeling beautiful, feeling unworthy of love makes achieving an orgasm and enjoying sex almost impossible for many. There's aerobic and physical worries. What if I lose my breath? What if I run out of strength? What if will I have a flare from exerting myself sexually? Sleep and libido. If I'm not sleeping well, I'm not going to be very prime, and I'm not going to be at my sexual peak. Libido, is there a testosterone issue, right? We know this. Medications can affect erectile performance or just libido overall. And then coexisting illness, again, vascular issues, as can be seen in somebody who cannot move for many years and gets hardening of the arteries and or diabetes. Certainly our smokers out there, we do not want you smoking, especially with MG, but those can affect sexual performance as well. So a lot to consider. So again, going back to this mood, if you're depressed or anxious, this can affect sexuality and intimacy. The mind is the most important sexual organ, in my opinion. Pain. Who wants to have sex or be intimate when you're in pain, right? Sleep. We talked about that. Feeling unsupportive. This is kind of something that it hits home for some MG patients. Look, we don't all have supported spouses or significant others or coworkers or friends or bosses, but when we feel hopeless or unsupported, the saddest thing happens. We don't feel worthy of love. Who would love someone like me in this situation? You start to say things, I would even understand if they would leave me, and you believe that. We'll talk about that a little more. Nourishment. If you're not well fed, if you're not able to take in food, and hydrate well, it's going to be very hard to perform athletically, or in this case, sexually. Just a little bit here I talked about. So some solutions, and I'll talk a little bit more about this. So it's the guide to intimacy here. Hydration, you should be ready to roll, just like you're going to play a sport or something. You should be hydrated, eat well, sleep well, and definitely, perform regular exercise to the best of your ability to increase your longevity. And we'll talk about that. Communication, knowing that someone loves you. These things are happening in your head. My spouse isn't, I'm not worthy of them, whatever. But sometimes talking about them, you might find that that's not the case at all. Maybe your spouse is nervous to talk to you about MG, doesn't want to make you upset, but it seems like they're standoffish, but maybe you're both just nervous to talk about it. Communication, express your concerns and fears openly. I want to have sex, but I'm nervous I might get sick during it. I might, lose my breath or something. But also be ready to hear the concerns and the fear of your non-MG affected partner. That's how we grow, right? Focus on foreplay, kissing, touching, being close, emotionally heighten the mood. Make someone feel cared for. It builds trust and increase the chance. It definitely increases the chance of a more positive sexual and intimate experience. And just from some planning point of views, a cold room, we know myasthenics do better with cold. It works like Mestinon. It allows acetylcholine to exert its effect. So cold room temperature, guys, if you can do it. And I would even consider planning Mestinon like some men plan Viagra. Okay, we're going to have sex, if I have room to take one, let's take a Mestinon. So kind of at my best shape here. The guide to intimacy, there's some things to consider. These are real world considerations. Have cold water. You want to stay hydrated. Take a break if you need to. Consider switching positions intermittently. The patient's partner may want to share in some of the physical work, right? So you're not just getting fatigued over and over. Counseling, if there's any kind of mental issue, if you don't feel worthy, if you truly feel sad or unsupportive, either solo therapy or group therapy can be considered. Check hormone levels if there's especially erectile dysfunction or failure to achieve orgasm. Testosterone, other medical issues, as I said, known to dull the libido, like thyroid or diabetes, are going to be important. And consider morning intimacy, guys. That's when an MG patient's going to usually be at their best. Cold room, morning, Mestinon, water, usually you're ready to go. Yes, these are common questions. Yes, you can use condoms, and yes, women can have an IUD placed, especially a non-copper one if they choose. However, speak to your physician before using medications like Cialis and Viagra. They are not classically known to worsen MG. However, there are several case reports where they did. And especially if you're unhealthy or unfit for blood, when you do that, it's going to dilate your blood vessels to allow blood flow to enter the penis, frankly, and you're going to lower your blood pressure doing that. So you always want to make sure with these kind of medicines that you're okay or safe to take them. And that decision is very individualized between you and your doctor. Again, be sure you're safe for sex. If you're not stable to have sex, MGFA 3, 4, make sure you talk to your physician about strategies and ways to go and see if you are truly safe for sex. Moving on to quality of life issues, social avoidance. Any number of MG symptoms can make you embarrassed or cause social anxiety. Driving avoidance, what if I get ptosis? And that can affect autonomy, employment, income, quality of life. Think of your work, right? A teacher with voice problems. How do you teach? Fear of exercise. I want to lose weight, but I fear my MG symptoms will flare up. I always say, People trivialize double vision, but go talk to a neurosurgeon or a truck driver, and that one symptom will highly debilitate them. MG and exercise. I got a super cool background here with a track. Coming in, thought of exercise can be a source of anxiety, fear, and frustration. I want to exercise. I'm upset that I can't. I worry I'll get sick. There's not even great data out there that I can easily find. My doctor doesn't seem to be able to point me in any clear direction of how to exercise an MG, and so people avoid it. The biggest threat to your health, actually, though, may become cardiovascular disease, like anybody else who doesn't exercise much. And that might affect you more so than myasthenia. You know, all of a sudden you get a little bit of double vision or something, but now you're having like diabetes, heart attacks, strokes, clogged carotid arteries. All of a sudden you have a bigger cardiovascular problem than you do a myasthenia problem. So I always say, I favor early disease modification. The gloves come off early. And the primary goal of any neurologist, really for any patient, but especially an MG patient, is I want to keep you moving. I want to keep you moving so you can feel confident and good doing all the things you did before, especially exercising. But let's dispel some of those fears, guys. Super counterintuitive findings. Guess what? A bunch of studies, and there's kind of a meta-analysis of maybe 5 or 6 of these interventional exercise studies in MG. Look, they showed mainly good things. They showed that the vast majority of people did not have an exacerbation. They might have noticed some worsening at first, but like not hospital worthy. We didn't just see ambulances picking people up at gyms all day. That was not what happened in the studies. In fact, they found that the vast majority of MG patients can perform it safely, especially MGFA 1 or 2, which is ocular or mild. Counterintuitively, you tend to improve your oxygenation, your mobility, and your strength by doing exercise over time. There tends to be an improvement in mood, fatigue, and sleep with exercise, and an improvement in strength and muscle endurance. And when we shock you with the repetitive nerve stimulation test that many of you have had, we actually see a reduction or an improvement in the decrement, which is pathognomonic for myasthenia typically. MG symptoms did not tend to exacerbate, again, when these protocols were followed. Let me talk about the protocols. Talk to your physician first, right? I don't know your complete medical history. For all I know, you could have a kidney issue or heart issue overlying, and you do need to talk to your doctor. Anybody does before they start an exercise regimen. But think about a cold room. Think about having cold liquids with you. Think about putting a cool towel around your neck. I love doing that. Just having you guys cold. You're going to feel good. And it's good for your muscles anyway. I like the kind of spray bottle I put here with the fan. You know that evaporative cooling is the quickest way to cool somebody with heat stroke, right? So fanning cold water over their body beats putting their hand in a bucket of ice. So really rapid cooling devices here. I would tell you that you should consider, if you do take Mestinon, taking it beforehand. Try not to run or exercise down these like back country roads by yourself. They're beautiful. Just like, you know, if you have a problem, I want to make sure you can get some help. Somebody's got to be around, you know. Guys, the first no, don't try to set any records out there. You know, your body tells you to take a break. Let's take a break and live to fight another day here. Do not exercise to fatigue. This is the weirdest thing to do because we've always gone to that last set where we're like, oh, and we get it. And now we're done. Do not exercise to fatigue. You kind of want to, I wrote here, you want to stop your set feeling like you could have done more. Like, why did I stop? Rest, hydrate, and cool, even if you don't feel like you need to, and then return for more. I promise these little things will allow you to continuously work out much more than if you just strain yourself into exhaustion each time. Sleep, eat, and hydrate before performing exercise. We talked about interval training. Guys, interval training, frequent breaks like anyone. Stretch before and after. Do not max out. You know, don't be the guy that's like, hey, I have a neuromuscular disease. Let's see if I can lift 500 pounds today. I'm not saying there may not be a role for that one day, you know, but like, that's a good way to you really got a lot of chips on the table doing that. I really like interval training with some lighter weight, some higher increasing numbers of reps with good breaks. If you're on a running machine, fixed rails. You know, these ellipticals that do that, don't do that. I want something fixed that if your legs give out or something, you can grab on, or bars on a treadmill. There's also be a kill switch. You ever see those red switches on the treadmill? So if heaven forbid you become acutely weak, I don't want you like falling off the treadmill. You want to pull that thing and have the machine come off. Alternate intervals of walking, jogging, and running if you'd like. Lower the weight and increase the repetitions and do that over time. That can prevent reaching fatigue and actually get you more time in the gym by not ending it prematurely. I would consider making someone aware at the gym. It's up to you, right? HIPAA, it's up to you. But I'd like somebody, a staff member, to know, oh, Tom has myasthenia here. And if I see him struggling and he can't talk, I want to know exactly what's going on. I want to know that EMS needs to be activated. I want to know, what's going on, inform other people. So maybe consider bringing them in on that and telling them, educate them on MG. And when your body says stop, please, guys, listen to it. The goal is to become healthy here, not to risk your safety. Naturopathy. I'm going to give you a little soapbox here because I'm kind of a naturopathic guy myself, but I don't like that people have been hijacking this term. So naturopathy is the hallmark of having a little Spanish mom that comes from a village in Spain, like me. Everything is olive oil. Everything is so good and fresh, and we didn't eat McDonald's and we didn't have soda. But my mom was not in a race to shove every supplement possible on earth into my body. That's not natural. I didn't see cave people doing that. I didn't see anybody doing that, in fact. And yes, supplements, they're medications, guys. They can cause hypervitaminosis. B6, hypervitamin B6 can cause an irreversible neuropathy. MG can potentially kill a myasthenic. I love these therapies, but I worry that many of them are being sold with unproven and unstudied claims promoting them. When I'm on Instagram, you might notice there's some bots that pop up that try to sell my MG patients a bunch of garbage. I see on there, it cured my HIV, it cured my hepatitis, it cured my, and I report these things to the FBI. They don't do anything about it, but I report them. And I don't want this to happen to you, right? So again, while there may be a role for supplementation for you, please speak to your physician about each supplement you're considering and take them under the care just so we can consider your myasthenia. So many things worse than MG. Also, if there's a reason you want a supplement, I want to know why. It's not that I won't agree to give it, to work with you with it, but like if you tell me it's because I'm fatigued, again, I want to look back at your sleep, your pain, your MG, your meds, because that might do the trick. Now, true naturopathy, the real naturopathy, it's not a race to put every exogenous factory-made pill chemical into your body. True naturopathy comes from maintaining the pillars of health. I kind of coined this term. I hope everybody agrees, but it's sleep, mood, nourishment, hydration, and exercise. If you are not sleeping like a champ, if you are not mood controlled, if you are not nourished and hydrating like a champion, and if you are not exercising, then guys, you're not doing yourself a service by talking about, elemental mercury infusions or something like that. These are real safe, easy ways to get you back on track. They tie into your MG, and naturally by helping your MG, we can help you achieve the pillars of health and save, having to go out, spend a bunch of money on this stuff. There are supplements that may be considered, but the point here is please work on the main pillars of health and talk to your physician with MG, especially about supplements, because so many of them can worsen MG. Okay, now consider some relaxation techniques. These are kind of, in a way, a mental exercise, an aerobic, and they can calm things down. They can facilitate sleep. Biofeedback, meditation, yoga, Tai Chi, and massage. And for postmenopausal women, actually, Tai Chi has some amazing data showing that it may be as efficacious as hormone replacement therapy for things like vaginal dryness and hot flashes or other postmenopausal symptoms. Now, lastly, I want to send you guys out with a farewell. I appreciate you guys listening to this. First of all, I want to say be well, and please don't ever give up. The journey of 1,000 miles begins with a single step, but you won't ever be walking the journey alone. And I see you and I hear you, and you're appreciated. And I want you to know that this watch and wait business is coming to an end. Remission is always the goal, and it is better to aim for perfection and miss than aim for imperfection and hit. And lastly, I want you to know that it is my greatest honor as a neurologist to serve all of you, the myasthenia gravis community. So thank you. And with that, I'll turn it over to Jenna, and I believe we're going into the Q&A portion.
Thank you. That was an amazing presentation, loaded with lots of great information. So we're going to jump right into the questions. Okay, the first one is, I've had 2 instances of vertebral artery dissection caused by minor events like sneezing. Could my MG and weak neck muscles have caused this due to my muscles not being able to properly support my neck during a sneeze?
Thank you for asking. kind of, but maybe not. The vertebral artery dissection is most commonly, by the way, for the gangs that don't, you have the carotid arteries in the front that go to the heart, and in the back, you have the vertebral, I hope I'm in frame here, the vertebral arteries in the back, okay? So they're the carotid arteries of the posterior circulation. Most commonly, a dissection occurs under mild trauma in a young female or young male with fibromuscular dysplasia. That's your homework, whoever asked this question. Fibromuscular dysplasia. Fibromuscular dysplasia is often a sign of wider autoimmune disease. You can see this in lupus. Sometimes you can see this in Sjogren's. Do they commonly coexist with MG? Yes. Can neck extensor weakness predispose you further to having a vertebral artery dissection? Potentially. I will say that a lot of MG patients don't have that. Most don't, right? So my point is, I would definitely consider talking to your doctor about looking at other autoimmune diseases coexisting with MG that could predispose you to have fibromuscular dysplasia and have a dissection. For people that don't know, there are several layers inside of the artery. And when a layer peels back and rips internally, that's called a dissection. It fills with blood, it forms a clot, and it can throw small strokes up into the back of the brain and frankly be catastrophic. So prevention is key. I'll bet you're on 2 blood thinners. Dual antiplatelet therapy is the key. But certainly looking for other autoimmune diseases that would have precluded you to have this. And if you do get a vessel image, asking the radiologist to comment specifically on fibromuscular dysplastic appearance would be crucial for you. Thanks for the question. That's a great question.
Thanks so much. Somebody else said this neck thing that I'm struggling with a lot. In fact, I made an appointment to go with a chiropractor. Would this be inappropriate?
You know, I don't want to make anybody upset here, but like, I doubt that'll help you. I mean, I never understood, you know, how high velocity shearing force on the neck is healthy. You know, the American Academy of Chiropractic can get all upset at me if they want. But I have put people in the morgue over this. You know, 1 in 400,000 neck adjustments results in a death in the United States. Doesn't sound like a lot, but if you're that one, it's not good. I don't understand how increasing inflammation by shearing force will help your myasthenia, a disease characterized by autoimmune mediated inflammation. And lastly, if it is a nerve issue, certainly adjusting it will provoke the issue. I would say that chiropractic has a role, but I don't like neck adjustments. The other stuff I don't mind. That's a personal opinion. I love massage. I love acupuncture. I love physical therapy. You know, I like biofeedback, but high shearing velocity force on the neck usually results in, to me, for occipital neuralgia, worsening of it, or increased inflammation, which may worsen myasthenia. And lastly, the way folks, those 1 out of 400,000 tends to die is a vertebral artery dissection that we just talked about. So that's a personal opinion. You'll get a lot of other people that might say go for it, but you know, we made it this far with myasthenia. I don't want a guy like auto decapitating you with shearing force on your neck that you may not need. That being said, it has a role in other places. There's a lot of other things you can do to probably help your neck, like fixing your MG, which is causing your head drop.
Thanks.
Great question.
Somebody has a good question along these lines too. What exercises can be done to increase strength in the neck in order to hold our heads up more easily?
Great question. Now keep in mind, you don't have an inherently weak neck. Does that make sense? Like you're not like someone who just hasn't been athletic or active and we're really trying to get your strength up. You have a neuromuscular blockade that even the most fit person, even a bodybuilder, right? Let's say I have one of these guys that can like push a brick wall with their head that I see in the gym sometimes. You know, that person, if I block the acetylcholine receptor, it doesn't really matter, right? So I always say the first thing you want to do to strengthen your neck is to fix your MG. That's the best way to do it. Now, absolutely beyond that, there are exercises that can help your neck. Mainly, and it depends. If we're talking headache, it's more of a chin tuck thing. If it's neck extensor muscles, well, then it's typically neck extension against resistance. I always support neck exercises done, at least at first, under the tutelage of a physical therapist, because they can help guide you. As you can see, there's a lot of room for injury by doing these wrong. So I would love to have someone do like a few sessions with a PT and have them really guide you through it. And that way you can go on doing them. So yes, there are strengthening exercises. However, a lot of times just fixing your MG is the key. Great question.
Great. This next one is dealing with upcoming chemo. So going into this blind as far as my MG goes, also need hip replacement. Yes, it feels like a lot, but taking it one day at a time right now. Any words for chemo or upcoming surgery?
Absolutely. Did you, and I'm so sorry, Jenna, I missed the first part. Did you say chemo or SIBO?
Chemo.
Chemo. Okay. And I don't want to get too personal, but I wonder if the chemo is for MG or cancer. There's two different, roles, but either way, I would tell you. So chemotherapy is draining, as you know, but it also has an incredible result for many in the end of the day. So focus your mind, get in touch with your star player, and know that this is a very temporary part of your life. And you're extremely brave for undergoing it, that down the road, hopefully there won't be a need as for that. If it's MG related, right? Hopefully there won't be as much of a need for it. That being said, you're taking steps to get yourself healthier. This is the definition of what I tell people, the students: fear the fire more than the hose. Chemotherapy is the hose, and there's a lot of things to fear about it. But if you need chemotherapy, then really your MG should be the thing we're fearing, right? So I'm proud of you for doing that. Hydrating, being nourished, getting yourself at your peak before that, mentally, physically, and having an outstanding support system, if possible, is the way to go. Addressing any concerns with your physicians, mental counseling if you need it. Who wouldn't need to talk to someone, right? I mean, I say that like, well, if you need it, I probably talk to someone before that just to make sure I'm all set. And just know that when you're in the worst part of it, it's not forever. This is to get you back on a bike, riding your bike, or back on the beach, or back dancing at the wedding, or holding your kid or grandson or granddaughter. So I'm proud to know you. The hip, surgically, definitely want to consider that that's going to provoke an immune response no matter what, right? It's a strategic stab wound if you think about it. So you're going to have we all know about surgical worsening. If you're the general consensus tends to be, if you're someone with well-controlled MG, we don't usually have to pre-treat you with something like IVIG beforehand. What we do is we talk to anesthesia, make sure that they don't use a prolonged neuromuscular blocking agent like succinylcholine, which again, your doctor can talk about with them directly. I love to have you be the first case of the day because you're at your best. I want to see Mestinon beforehand, unless you're going to be intubated for a prolonged period of time. The reason why is it can be harder to take the tube out because Mestinon increases secretions. I want to make sure you're in a center that can handle an MG crisis if it happens, heaven forbid. So like, is there a neurologist? Do they know about MG? Do you have an ICU? Do you have, all the things that go into just extra layers of safety. So having a good talk with the neurologist and the anesthesiologist, and then if you are not stable, considering something like pre-treating with IVIG or whatever care, you mentioned maybe chemotherapy like rituximab or Cytoxan, that could be applicable too. The hip could be from old age, but also consider weight. Consider compensation onto the hip from limping on the other side due to a disc bulge. Consider prednisone wearing down your bones. Consider osteopenia or osteoporosis. These are the thought processes that got to go into this. And I'm proud to be on your team. I love this question. And hip surgery, something that simple, can be intimately tied into MG. So with some considerations like that, you can get through the surgery safely. And I want you to know that I'll be thinking of you as you get your chemo. I hope it goes well.
So much. That's great. Okay, this next one is, could difficulty urinating for men be a secondary or tertiary MG issue?
That's an excellent question. I mean, the first thing you think about especially in an older man, and remember, it's a bimodal disease, meaning the mode. So it's younger females, typically 2-to-1, like 20 to 40 years old. And then it tends to be older men. So relatively older, right? 50 to kind of 80, depending on what you look at. So the first thing with problems like hesitancy, trouble starting a stream, trouble maintaining a stream, you always want to think of the prostate. And I always say you always want to check your PSA with the doctor. You want to consider a urology consult first and foremost to make sure there's no anatomic or just natural male issues. Now, on the other hand, MG in itself, we mentioned, probably doesn't affect the bladder directly, but I would want to know if you have other autoimmune problems. And I would also want to know if you're pre-diabetic or have diabetes, because those can affect the bladder. And then finally, I'd look at your medicines and make sure that some of those aren't messing with them. Some of the medicines out there can cause urinary retention or the opposite, urinary incontinence. So certainly considering prostate and just regular male urogenital prostatic issues, but then also looking at meds and other MG considerations that I mentioned, especially concomitant diseases more likely to affect the bladder, diabetes, prediabetes, or other autoimmune diseases are major considerations. That's a great question.
Great, thanks. I know we're at time, but if you're okay, we'll keep going because there's
a lot
of questions.
Unless you guys are tired of me, I'm in it. I'm in it to help anybody I can.
Okay, great. Thank you. So this next one is, how do you tell the difference between MG weakness versus steroid myopathy weakness?
Awesome question. We're going to upgrade that to awesome question. Steroid myopathy. Thanks for bringing that up. So myopathy, as opposed to neuropathy or neuromuscular junction disorder, refers to a pure disease in the muscle. Most of us know the muscular dystrophies, which are genetic, typically dystrophinopathies like Duchenne's muscular dystrophy or Becker's, the more mild Becker's muscular dystrophy. There's limb-girdle muscular dystrophy. There's facioscapulohumeral muscular dystrophy. I could go on and on. Primary diseases of the muscle, of which MG is not. However, there is a myopathy overlay syndrome with both lupus and myasthenia. So you can have inflammation or myositis or muscle weakness from a direct muscle injury. And as I mentioned, right, coexisting autoantibodies. You can have, there is an autoimmune myopathy panel that you can get in the blood. And finally, when you talk about steroid induced, remember the EMG is going to be normal. The EMG can show myopathic patterns in non-steroid induced myopathies, as can be seen in the inflammatory myopathies, in which I will see abnormal spontaneous activation with the needle in, like fibrillations or positive sharp waves, which are markers of inflammation on the nerve, let's say, or nerve injury. So electrodiagnostics can be helpful. Now, if it was steroid, the EMG will be normal. So what I always do is look at a CK, creatine kinase. Typically, the CK is elevated. Sometimes you can have a CK normal, EMG normal myopathy. I would tell you that it tends to be out of proportion to the MG weakness. So like you might have somebody whose eyes and stuff are fine, and now it's proximal, it's shoulders and hip weakness, not hand and foot. So proximal. It tends to be constant and worsening, unlike MG, which is fluctuant, improving in the morning and worsening at night. It will not respond to mestinon at all. It'll get worse with steroids if it's steroid induced. Keep in mind, statins or cholesterol medicines can cause a statin-induced myopathy. Diabetes can cause a myopathic process in some. So usually it's the pattern of weakness, the onset. I look at the labs. Is there blood in the urine? Is there myoglobin in the urine? What is the CK or creatinine kinase level in the blood? What does the EMG show? If need be, I can get a muscle biopsy. In the end of the day, though, typically this is going to be a worsening, more constant pattern that is not proportionate to your MG weakness, and it stands out in the proximal muscles. If it is inflammation or myositis, it will also be extremely painful. Great question.
So this next one is, what about taking Advil PM to induce sleep?
You know, I'm just going to say like not good overall. You could, once in a while, anybody could do that. Right? I'm going on a flight or something. If you're doing that daily, I mean, talk about doing that on top of steroids. I mean, that's the worst of both worlds. They'll both eat up your stomach. And then when you finally bleed from an ulcer, the Advil will thin your blood. So you bleed bad enough that the GI guy will have to like emergently go down there and cauterize it. So muy malo, very bad to do regularly, I think. Once in a while, that's fine. But the question you want to know is, why do you need help sleeping and how can we fix that? Is it neck pain? Is it stress? Do you have apnea? Do you need a sleep study? Is your diaphragmatic breathing suboptimal? Do we need to work on your MG? Are there medicines like steroids keeping you up? Are there medicines like Mestinon making you pee? Do you have a sleep partner that snores? You know, do you have a warm room because your sleep partner likes it warm, but it worsens your MG? I always say I can help you get to sleep, but what I want to know is, why do you need help getting to sleep? And that's the true answer. Melatonin can help MG patients sleep, but please beware, because often melatonin is sold in combination with magnesium, which would worsen MG. A lot of times you see they market it as like sleep plus. Well, that plus is usually melatonin with magnesium, and that would be very bad. So whatever you do decide on, run it by your physician. Keep in mind, chronic ibuprofen use can preclude to medication overuse headache, high blood pressure, kidney injury, and stomach ulcer. Once in a while, not a big deal. Why do you have trouble sleeping is the key. Great question.
Great, thank you. This next one is, I have daily tinnitus and disequilibrium. I have intermittent vertigo. Could that be from MG or a secondary effect of MG?
Thanks for asking. Yes, secondary effect potentially, or not related at all. The most common cause of tinnitus, of course, is hearing loss, usually caused by presbycusis or hardening of the inner osseous structures in the ear, like the stapedies or the anvil, that are vibratory and they help conduct sound, like a guitar string, and they harden over time. You tend to have problems hearing with background noise at first, tends to come in older age, and you have tinnitus. The other ways you can have tinnitus are by medication use. There's a medication called gentamicin, which is an antibiotic, which can both worsen MG and cause tinnitus. Aspirin can be a major cause of tinnitus, a massive cause of tinnitus. Now, I'm not saying you don't need it to prevent a heart attack, right? But talk to your doctor if you need aspirin, because that almost always in an ENT clinic, they want to stop it and see if it helps, and maybe put you on Plavix or clopidogrel if you need an antiplatelet. Migraine, you can have migrainous vertigo and tinnitus. There's also something called Meniere's disease. Al Shepard was, I believe, going to be the first guy on the moon, not Neil Armstrong, but he was grounded after he had Meniere's disease, which is characterized by the triad of deafness or hearing loss, vertigo, which is the room spinning, not lightheadedness. Lightheadedness is I'm going to pass out. Disequilibrium is also not vertigo. Disequilibrium is I just got off a boat. I don't know where I am. Vertigo's ring around the rosy. We spin you around 1,000 times in the tires swing. That's vertigo. So vertigo, tinnitus, hearing loss, you think of Meniere's, in which case we have otic diuretics, like triamterene, that can be done under the guidance of a neuro-otologist, ENT, or sometimes neurologist. MG, neuromuscular blockade in itself does not produce tinnitus, but migrainous vertigo. You can have cervicogenic dizziness, meaning the neck can be impinged or injured. TMJ, temporomandibular joint dysfunction, which is like jaw pain, can also cause tinnitus through the activation of the auricular temporal nerve, and cause a headache syndrome. You can have clicking or grinding of the jaw that can cause tinnitus. And lastly, there's something, of course, vascular issues like aneurysm or blood flow problems can cause it. And there's something called semicircular canal dehiscence syndrome, which you can get a CT CAT scan of the temporal bone without contrast. And sometimes the actual, like, picture a cabinet you fix to your wall in the house, and then the cabinet comes off. The inner ear structures are kind of stuck to the skull, and they can come loose or come off, dehiss, and you will have tinnitus constantly. So all of those things can be considered. I recommend a neuro-otology clinic, which is like if an ENT and a neurologist produced a doctor child. And it's specialized on neurologic and ENT-based diagnostics and therapeutics. And also start with a basic audiology hearing exam if you haven't already.
Thank you. Okay, I think we'll do one more question. I'm beginning a very part-time job with an unvaccinated coworker. I am vaccinated. We will be working closely and presumably masked. Is this advisable for me? And then they say, I'm not on any medication, but hope to be on something soon.
Well, here's the thing. First thing I want to say to the MG community is you are not by and of yourself immunosuppressed. Okay. MG does not lower your immune system at all. Actually, it's the entire opposite, right? An AIDS patient who has no immune system would never have an autoimmune attack. They have no immune system to attack themselves. You can't have an autoimmune attack when you don't have an immune system. You walk outside and you get infections all day. You have an immune system that not only shoots every bad guy, it also shoots the bank guard. It goes after you every time it goes after everything else. And that's because an antibody is enticing it to do that. So you are able to fight off any normal pathogen that anybody else can. The problem is when your immune system wakes up, you also have an MG flare usually. So not getting sick is paramount. And you did a good job by getting your vaccine. Way to go. Now, the unvaccinated person who gets COVID, if they do get it, the transmission rate is much lower in a vaccinated patient. And I would tell you, I wouldn't give up the job. If you're distanced and masked, I mean, I wouldn't be inclined to give up that job if you're vaccinated. Now, you can be immunosuppressed by your medication. That's the whole point. That's what we do every day is try to immunomodulate you, right? You have this overreactive immune system that we try to modulate. Now, that could preclude you, depending on the medication, to get infections in general, but many of them have been shown to not specifically show a generalized risk to COVID. So what I would say is, you have to talk to your physician about your individual immunosuppressant, but generally speaking, you're not immunosuppressed, you're immuno-overreactive. If you mask and distance and are vaccinated, you should be okay. If you have a medicine that specifically immunosuppresses you, well, then in a way, it kind of wouldn't even matter. We would always want you to have a mask on, depending on how immunosuppressed you are and what it is. So a specific talk with your physician about what medicine you have. But let's say you had a medicine that wasn't known to put you at risk for COVID, let's say, and that was your immunomodulator. I'd say go ahead and take the job. And I hope that person decides to come around and get vaccinated for everybody's sake. But I wouldn't lose the job if they're distancing and wearing a mask if you're vaccinated. And as long as you're not on a group of specific medications that can make you highly immunosuppressed, in which case that's not just that coworker, that could be anybody you run across in the daily comings and goings of being in a community. Right. Great question.
Dr. Pitts, thank you so much for a very informative session. Thank you everybody for joining us today. We really appreciate all the questions and the comments. There's a lot of thank yous in the comments feed as well. Please be on the lookout for additional wellness series webinars on the MGFA website. And we look forward to seeing you all soon.
And thank you all for serving as my teacher too, because whatever you learned here today, I want to let you guys know I learned so much more from interacting with you. So I appreciate everybody at the MGFA and all of you for having me today. Thank you.
Thanks so much. Take care.